What if the buzzing in your ears is not just a nuisance, but the symptom of a whole industry built around managing the noise, an industry people call the $12 billion medical secret? Before you imagine a conspiracy, hear this. Millions of dollars flow through hearing devices, therapies, and long-term symptom management every year. That economic reality shapes what gets talked about most and what gets barely mentioned. If your ears are ringing right now, that matters because some of the most impactful steps you can take are low-cost, under-discussed, and surprisingly effective at improving sleep, focus, and your day-to-day life. Tinnitus is not a single disease. It's the perception of sound, ringing, buzzing, whooshing, hissing, or pulsing when there's no external source. For some people, it's a faint background whisper they notice in quiet rooms. For others, it's loud enough to wake them at night, wreck their concentration, or twist mood into anxiety and depression. It can be constant, intermittent, worse in one ear, or synchronized with your heartbeat. The sound itself is just the symptom. The causes are many, and the right path forward depends entirely on which underlying pathway is at work for you. Tell us in the comments, is your tinnitus a steady ring, a beat that follows your pulse, or a sudden onset? Share which ear and when it's worst, constant, at night, or after noise exposure, so we can tailor future guidance. First, understand the main types you might be hearing. That helps you know what tests to ask for and what kind of help to seek. Most tinnitus is subjective, only you can hear it. Subjective tinnitus usually comes from damage or altered activity somewhere in the auditory system, the inner ear, the auditory nerve, or the brain's sound processing centers. Objective tinnitus is rarer. A clinician can sometimes detect the sound, meaning there is a physical source in or near the ear, for example, turbulent blood flow or a muscle spasm. Pulsatile tinnitus is a subtype you feel in time with your heartbeat. It often reflects vascular issues and warrants a cardiovascular check. Somatic tinnitus is linked to the jaw, neck, or muscles. Changing the position of your jaw or moving your neck can change the perceived sound. Now, the causes. Think of them as categories that map to different solutions. Noise exposure and age-related inner ear damage. The tiny hair cells inside your cochlea translate sound vibrations into nerve signals. Loud noise, a single very loud event, or repeated exposure over years can damage those hair cells. Age-related changes do the same thing gradually. Action: protect your ears from loud sound, get a hearing test. A hearing aid or sound therapy often helps when hearing loss is present. Ototoxic medications and chemicals. Certain drugs and chemicals can harm the ear. Examples include some high-dose pain relievers, certain diuretics, some antibiotics in the aminoglycoside family, and some chemotherapy agents. Action: do not stop any medication without talking to your doctor. Ask your clinician whether any of your prescriptions are potentially ototoxic and whether alternatives are available. Vascular causes and pulsatile tinnitus. If the sound follows your pulse, it can be from turbulent blood flow, a vascular malformation, or high blood pressure. Action: get evaluated. An ENT and possibly a vascular workup are appropriate. Controlling blood pressure and treating vascular issues can alter the sound. TMJ and neck-related, somatic tinnitus. Jaw clenching, dental misalignment, or neck dysfunction can change tension patterns and feed abnormal signals into the auditory system. Action: a dental evaluation, physical therapy, or a TMJ specialist may offer relief. Neurological and central causes. Migraines, multiple sclerosis, or changes in the auditory pathways in the brain can present with tinnitus. Action: if you have neurological symptoms, weakness, numbness, visual changes, seek medical evaluation promptly. Metabolic and nutritional contributors. Low vitamin B12, thyroid dysfunction, poorly controlled diabetes, and other metabolic imbalances can be associated with tinnitus in some patients. Action: basic blood tests, thyroid, glucose/A1C, and B12 are reasonable to discuss with your provider. Stress, anxiety, and sleep disorders. Tinnitus amplifies stress, and stress amplifies tinnitus. Sleep deprivation and untreated sleep apnea can make the perception worse. Action: sleep hygiene, cognitive behavioral approaches, and sleep studies when indicated can reduce the impact even if the sound remains. Earwax infections and middle ear problems. Sometimes the cause is simple. Earwax blocking the canal, an ear infection, or fluid behind the eardrum can create or worsen tinnitus. Action: an otoscopic exam and appropriate ENT care can quickly change the picture. Hearing loss that goes unnoticed. Tinnitus is often the first sign of hearing loss. Even mild loss in specific frequencies can lead the brain to fill in sound, producing tinnitus. Action: an audiogram is essential. Treating hearing loss with hearing aids or other amplification often reduces tinnitus severity. Those are the main categories. For each, the one-line rule is, identify the root cause, then match the intervention. But the practical problem many people encounter is that care often stops at symptomatic management. Devices and long-term therapies that reduce awareness but don't always address reversible drivers. That's where the framing of the $12 billion medical secret comes in. There's a large market for long-term management of hearing conditions. That can mean many patients are given expensive devices and coping strategies without being fully evaluated for low-cost, treatable contributors like medication effects, blood pressure control, sleep apnea, or TMJ dysfunction. Saying that a multi-billion-dollar industry exists is not an accusation. It's an observation that helps explain why some simple measures are under-discussed in routine practice. What can you do at home right now while you arrange professional evaluation? Reduce exposure to loud sounds and protect your ears. Even short bursts of volume above safe thresholds can worsen tinnitus. Use ear protection around loud environments. If you use headphones, lower the volume and favor noise-canceling models that allow safe listening at lower volumes. Introduce sound enrichment. Complete silence often makes tinnitus more noticeable. Low-level background sound, a fan, soft music, or a sound generator can mask the perception long enough to improve sleep and concentration. Many people find a white noise machine or an app helpful, especially at night. Practice stress reduction and sleep hygiene. Mindfulness, breathing exercises, gentle yoga, and cognitive techniques that reduce reactivity to tinnitus often make a dramatic subjective difference. Sleep is fragile in tinnitus patients. Regular sleep schedules and treating possible sleep apnea can improve both tinnitus and daytime functioning. Avoid substances that may amplify symptoms. Caffeine, nicotine, and excessive alcohol can increase perception in some people. Try a 2-week trial of reduced intake to see if symptoms change. Review your medications with a clinician. If you're taking medications that are potentially ototoxic or that interact with other risk factors, ask whether alternatives exist. Don't stop medications on your own. Get a hearing test and ENT evaluation. An audiogram, otoscopic exam, and possible referral to ENT or neurology are essential first steps. If your sound is pulsatile, new, or accompanied by neurological signs, ask for an expedited evaluation. Imaging or vascular studies may be needed in select cases. These steps are cheap, safe, and often overlooked. They are the exact measures that don't require ongoing device subscriptions or lifetime purchases, which helps explain why they are not always emphasized in every clinical visit. Now, let's talk about therapies and interventions that patients commonly encounter and how to weigh them. Sound-based therapies. These range from simple masking with white noise to structured sound therapy programs designed to retrain the brain's response to tinnitus. Evidence supports the idea that controlled sound exposure can lessen tinnitus annoyance over time in many patients. If you have measurable hearing loss, amplification via hearing aids often provides both improved communication and a reduction in tinnitus perception. Hearing aids don't cure tinnitus, but for people whose tinnitus is tied to hearing loss, amplification can be one of the most effective tools. Psychological approaches. Cognitive behavioral therapy, CBT, and other counseling strategies do not remove the sound, but they change how you respond to it. Numerous studies show that altering the emotional and attentional response to tinnitus reduces distress, improves sleep, and restores functioning. CBT for tinnitus is considered one of the most evidence-backed non-device approaches. Tinnitus retraining therapy, TRT. TRT combines sound therapy with counseling, aiming to habituate the brain to the tinnitus signal. For selected patients, especially those highly distressed, TRT can be helpful, though it requires specialized providers and a commitment of time. Physical therapy and dental approaches. If your tinnitus changes with jaw movement, chewing, or neck position, targeted physical therapy, posture correction, or dental work addressing TMJ dysfunction may reduce symptoms. These are often overlooked unless a clinician specifically checks for somatic modulation. Medications and injections. No medication is universally accepted as a tinnitus cure. Some medications can reduce distress or comorbid symptoms like anxiety or insomnia. Others have shown mixed or limited results in trials. Steroid injections may be used in sudden sensory neural hearing loss where inflammation is suspected. Any medication choice should be carefully weighed with your clinician. Surgery and invasive procedures. In rare cases, for example, certain vascular anomalies or structural problems, surgical correction can address an objective cause of tinnitus. These are specialized interventions reserved for clearly defined pathologies and require careful risk-benefit discussion. Supplements and nutrients. People ask about these constantly. The evidence varies, so I'll flag each option with a brief label for how strong the supporting data is and a quick safety note. Magnesium. Moderate. Some supportive studies. Magnesium plays a role in inner ear blood flow and cellular metabolism. Some trials suggest magnesium supplementation may protect against acute noise-induced tinnitus or lessen symptoms for certain people. Safety. Usually well tolerated at typical doses, but high doses can cause diarrhea and interact with some medications. Check kidney function. Vitamin B12. Weak to moderate. Benefit mainly in deficiency. In people with confirmed B12 deficiency, supplementation can improve neurological function and has been associated with tinnitus improvement in those subgroups. Safety. Supplementation is generally safe when deficiency is documented. Routine high-dose use without testing is not advised. Ginkgo biloba. Indefinitive to weak, mixed results. Ginkgo is often promoted for tinnitus, and some studies report benefit while others do not. If considered, choose standardized extracts and discuss possible interactions with blood thinners and other drugs. Zinc, Indefino. Trials are mixed, and benefit appears limited to those with documented deficiency. Excess zinc can cause adverse effects and interfere with copper absorption. Melatonin, moderate for sleep, weak for tinnitus per se. Melatonin can improve sleep and may indirectly reduce tinnitus distress. Some small studies suggest improvements in sleep quality and tinnitus perception, but melatonin's primary utility is sleep regulation. Safety. Generally safe in short-term use. Discuss possible interactions and morning drowsiness. CoQ10 and other antioxidants. Weak/Indefino. Studies are limited and inconsistent. For most people, evidence is not strong enough to recommend routine use solely for tinnitus. Omega-3 fatty acids, vitamin D, and other general supplements. Indefino. These have broad health benefits in certain contexts, but their direct effect on tinnitus is not well established unless a deficiency or clear vascular/metabolic linkage exists. A few important rules when considering supplements. Get blood tests before starting high-dose regimes. Disclose all supplements to your doctor. They interact with medications, and avoid high doses without clinical oversight. None of these supplements should replace an audiologic or medical evaluation. Safety tip. Be especially cautious with over-the-counter products promising rapid cures or dramatic timelines. Clinical research rarely produces such consistent, universal outcomes. If a product sounds too good to be true, it probably is. That brings us back to the $12 billion framing. The hearing and tinnitus market includes hearing aids, cochlear implants, consumer sound masking devices, app subscriptions, supplements, and therapy programs. The size of this market can influence what's promoted, but it doesn't mean that effective, low-cost measures are never recommended. It means you should be informed and ask the right questions. What is this treatment intended to do? Is it managing symptoms or addressing a root cause? What evidence supports it? Is there an alternative that's less expensive or reversible? So what should your immediate plan look like? Here's a pragmatic, evidence-oriented checklist you can act on today. Step 1. Document your tinnitus. Is it unilateral or bilateral? Pulsatile. When did it start? Suddenly after an event or gradually? What makes it worse? Loud noise, stress, jaw movement, or certain foods? This history guides testing. Step 2. Arrange an audiology exam and ENT consult. You may need an audiogram, emittance testing, and possibly imaging if the presentation suggests vascular or neurological cause. If you have sudden onset or rapidly worsening tinnitus, seek expedited evaluation. Step 3. Review medications. Bring a list to your clinician and ask about potential ototoxic agents. Step 4. Trial immediate lifestyle adjustments. Ear protection, sound enrichment at night, stress reduction, sleep optimization, and a short period of reducing caffeine, alcohol to observe any change. Step 5. Get targeted blood tests. Thyroid, B12, glucose/A1C, and any labs your clinician thinks appropriate based on your history. Step 6. If your tinnitus is linked to jaw or neck movement, ask about a somatic evaluation, a dentist with TMJ expertise, or a physical therapist who works with cervicocranial dysfunction. These are actionable, low-risk steps. They also shift the focus from being a passive consumer of long-term symptom management to being an empowered investigator of the cause. There are 3 pitfalls I want you to avoid. First, don't accept a one-size-fits-all solution. Tinnitus is heterogeneous. What helps one person may do nothing for another. Second, don't chase miracle cures or dramatic timelines. Improvement is often gradual. Third, don't skip medical evaluation because you fear the worst. In many cases, early assessment unlocks straightforward fixes. You may be wondering about the therapies that often make headlines: novel drug trials, neuromodulation devices, and implantable systems. These are exciting from a research perspective, and some will become part of routine care for carefully selected patients, but they are not universal fixes today. Clinical trials are ongoing, and broad claims should be viewed skeptically until replicated in large, peer-reviewed studies. At this point, you might feel a mixture of relief and frustration. Relief because there are many practical steps you can take today. Frustration because the path from diagnosis to relief is rarely linear. That tension is real. The same complexity that gives rise to lucrative markets also creates opportunity for simple, overlooked interventions. Next, we need to dig deeper into 2 critical arenas: the specific therapies you're likely to be offered and the quality of evidence behind them. We also need to unpack which low-cost measures are actually backed by research versus which are mostly marketing. Understanding those distinctions will change how you spend your time and money and could change how loudly that ringing affects your life. Next, we dig into the 2 arenas that make the biggest difference: what your clinician will probably offer you and what you can reasonably try at home with low risk and little cost. I'll walk through the evidence quality for each option, what to expect, and exactly how to prioritize actions so you don't waste money or time chasing treatments that won't help your specific type of tinnitus. Therapies you're likely to be offered and how to weigh them. Sound-based approaches: masking, enrichment, and retraining. What they are: simple masking uses a constant, low-level noise, white, pink, or natural sounds, to reduce the contrast between tinnitus and silence. More structured sound therapy programs use tailored tones, fractal sounds, or progressive exposure designed to reduce the brain's attention and reactivity to the noise. Tinnitus retraining therapy, TRT, pairs sound therapy with counseling to promote habituation. Evidence snapshot. There is reasonably strong clinical support that controlled sound exposure and habituation approaches reduce the distress caused by tinnitus for many people. Sound enrichment at night and during quiet tasks often gives immediate subjective relief even if it doesn't eliminate the underlying source. Practical expectation. Expect partial relief in annoyance and improved sleep in weeks to months for many users. Masking can provide immediate comfort. Retraining requires commitment. How to use it. Begin with a low-level background sound at night: fan, white noise machine, or an app. If you qualify, ask an audiologist about a structured program or TRT referral. Caveat: These approaches manage perception and distress. If your tinnitus is from an identifiable, treatable cause, e.g. medication-related or vascular, sound therapy should be combined with targeted medical care. Hearing amplification, hearing aids, remote microphones, and OTC devices. What they are: hearing aids restore or amplify sounds that your ear no longer picks up, reducing the brain's tendency to fill in gaps with phantom noise. Many modern hearing aids include built-in sound generators or tinnitus programs. Evidence snapshot. For people whose tinnitus is associated with measurable hearing loss, amplification is one of the most consistently helpful tools for reducing tinnitus awareness. The benefit often comes from improved hearing, reduced listening effort, and reduced attention on tinnitus. Practical expectation. If your audiogram shows hearing loss, a properly fitted hearing aid often reduces perception or annoyance of tinnitus. It is not a guaranteed cure. How to use it. Have a full audiologic fitting and counseling session. Try amplification for several weeks to judge benefit. Cost consideration. Hearing aids can be expensive. Ask about trial periods, insurance coverage, and over-the-counter alternatives for mild losses. Don't buy the cheapest device without a proper fitting. Fit and tuning matter. Psychological treatments, CBT, ACT, counseling. What they are: cognitive behavioral therapy, CBT, specifically adapted for tinnitus, teaches skills to reduce catastrophic thinking, shift attention away from the sound, and improve sleep and functioning. Acceptance and commitment therapy, ACT, and mindfulness-based interventions have similar goals. Evidence snapshot. CBT has strong evidence for reducing tinnitus-related distress and improving quality of life, even when the sound persists. Practical expectation. You will learn skills that change how you respond to the sound. Measurable improvements often appear after several sessions. How to use it. Referral to a clinician experienced in tinnitus-focused CBT is ideal. Some digital CBT programs have shown benefit, but check credentials and evidence before buying. Physical and dental approaches. TMJ, neck, posture. What they are: if jaw, dental, or cervical spine dysfunction modulates your tinnitus, meaning the sound changes when you move your jaw or neck, targeted therapies such as physical therapy, posture correction, or TMJ dental treatments can reduce symptoms. Evidence snapshot. For somatic tinnitus, physical therapy and dental interventions can be effective in selected patients. The key is identifying somatic modulation during clinical assessment. Practical expectation. Improvement is possible, especially when tinnitus is clearly influenced by jaw/neck movements. How to use it. Ask your ENT or audiologist whether somatic testing was done. If so, pursue a referral to a physical therapist or a dentist experienced in TMJ disorders. Medications and injections. What they are: there is no universally accepted drug that cures tinnitus. Medications are sometimes used to treat associated symptoms, anxiety, insomnia, or severe distress, or to reduce inflammation in cases like sudden sensory neural hearing loss. Evidence snapshot. Trials for many pharmacologic agents show mixed or limited results. Some drugs reduce associated anxiety or improve sleep, which indirectly improves tinnitus coping. Practical expectation. Medication may help with sleep or distress, not necessarily the phantom sound itself. Steroids may be used acutely for sudden hearing loss when inflammation is suspected. How to use it. Any medication should be prescribed and monitored by a physician. Discuss potential side effects and interactions. Medications. What they are: in rare cases, vascular anomalies, glomus tumors, superior canal dehiscence, or other structural causes, surgery may fix an objective source of tinnitus. Evidence snapshot. Surgery is effective only when a clear, treatable lesion is identified and the potential benefits outweigh risks. Practical expectation. Not a routine option, reserved for specific anatomical causes confirmed by imaging and specialist evaluation. How to use it. Discuss risks, realistic outcomes, and second opinions before considering invasive procedures. Emerging technologies, neuromodulation, implants, and drug research. What they are. Experimental approaches include electrical stimulation, bimodal stimulation, sound combined with mild electrical stimulation of the tongue or skin, and investigational drugs targeting inner ear biology or neural circuits. Evidence snapshot. Early trials show promise in select populations, but large, replicated trials are still needed. These treatments are not yet standard of care for most patients. Practical expectation. These may become options in specialist centers or clinical trials.
Manage expectations. Early reports are encouraging but not definitive. How to use it. If interested, explore clinical trials at academic medical centers and discuss feasibility with your ENT. Practical, evidence-oriented home measures you can start today. 1. Protective hearing habits. Why it matters. Preventing further damage is the single most important long-term action. Repeated loud exposures accelerate cochlear hair cell damage and worsening tinnitus. How to do it. Use foam earplugs or reusable flanged earplugs in noisy environments, construction, loud concerts, mowing, and limit headphone volume. A helpful rule is keeping personal audio devices at or below 60% of max volume for no longer than about 1 hour at a time. Also favor noise-canceling headphones to reduce the need for higher volumes. Expectation. Reduces risk for new damage and may lessen flare-ups after loud events. 2. Sound enrichment for sleep and focus. Why it matters. Silence highlights tinnitus. Soft, continuous background sound reduces contrast and improves sleep. How to do it. Try a white noise machine, fan, or an app with nature sounds. Start with low volume, not to mask, but to smooth the auditory environment. Expectation. Immediate improvement in sleep onset and reduced nighttime awareness for many. 3. Stress management and sleep optimization. Why it matters. Stress and poor sleep amplify tinnitus. Reducing arousal lowers perceived loudness and distress. How to do it. Create a fixed sleep schedule, reduce screen time before bed, practice relaxation, deep breathing, progressive muscle relaxation, short mindfulness sessions, and consider CBT for insomnia if sleep does not improve. Expectation. Better sleep often reduces daytime reactivity and perceived loudness. 4. Short dietary experiments, low risk. Why it matters. Some people notice sensitivity to caffeine, alcohol, or large sodium loads. The evidence is mixed, but short trials are low cost and low risk. How to do it. Try a 2-week reduction in caffeine and alcohol to see if perception changes. If your diet is very high in sodium, try modest reductions to see if tinnitus fluctuates. This is more relevant for pulsatile tinnitus tied to blood pressure or fluid shifts. Expectation. Some patients experience modest benefits. Results vary. 5. Targeted exercise and cardiovascular health. Why it matters. Vascular health affects blood flow to the ear. Uncontrolled hypertension, high cholesterol, and poor circulation can worsen pulsatile or vascular-related tinnitus. How to do it. Regular aerobic activity, blood pressure control, smoking cessation, and treating sleep apnea all support better vascular health. Expectation. Indirect benefit, better cardiovascular control may reduce some types of tinnitus and improve overall resilience. Supplements, what the evidence actually supports, and how to approach dosing safely. A note up front. Most supplements have limited or mixed evidence for tinnitus. They are best considered when a deficiency is documented or when used as adjuncts under medical supervision. Below, I list commonly discussed options with the evidence label that reflects the current scientific landscape. If you try any supplement, tell your provider and confirm relevant labs first. Magnesium, label moderate, conditional. Rationale. Magnesium supports cellular metabolism and blood flow in the inner ear. Some studies suggest it helps prevent acute noise-induced tinnitus and may reduce symptoms for specific people.
Typical supplemental dosing reported in studies in clinical practice, commonly 200 to 400 milligrams per day of magnesium citrate or glycinate. Dosing should be tailored for kidney function. High doses may cause diarrhea. Safety. Check kidney function if you have renal disease. Magnesium interacts with some medications. Vitamin B12, label weak to moderate, benefit mainly when deficiency is present. Rationale. B12 deficiency can cause neurologic symptoms, and correction can help those whose tinnitus is associated with deficiency. Typical dosing. When deficiency is confirmed, oral or intramuscular repletion is done under clinical guidance. Many over-the-counter B12 supplements are 500 to 1,000 mcg, which are generally safe for most people. Safety. Generally safe, but test first. Routine high-dose use without evidence of deficiency is not recommended. Ginkgo biloba, label indefinito, weak, mixed results. Rationale. Some trials suggest small benefits, others show no effect. Mechanisms proposed include improved microcirculation. Safety. May interact with blood thinners and increase bleeding risk. Discuss with your clinician before starting. Zinc, label indefinito, possible benefit only with deficiency. Rationale. Trials are mixed, benefit appears to be limited to people with low zinc levels. Safety. High doses can be harmful and interfere with copper absorption. Test levels before prolonged high-dose use. Melatonin, label moderate for sleep, weak for tinnitus itself. Rationale. Melatonin improves sleep, and better sleep reduces tinnitus distress. Some small studies show sleep and tinnitus perception improvement. Typical dosing. Low-dose melatonin, 1 to 3 milligrams at night, is commonly used. Start low and monitor daytime grogginess. Safety. Short-term use appears safe for most. Discuss if you take sedatives or have autoimmune issues. Coenzyme Q10, omega-3s, vitamin D, and other antioxidants. Label indefinito weak for direct tinnitus benefit. Rationale. These can be relevant if you have documented deficiencies or cardiovascular risks, but evidence for tinnitus-specific benefits is limited. Safety. Use under guidance if you have comorbid conditions or take anticoagulant medications. How to approach supplements responsibly. Get baseline labs when appropriate, B12, vitamin D, basic metabolic panel, before starting high-dose regimens. Use deficiencies to guide therapy. Be transparent with your clinician about all supplements. They can interact with prescribed medicines. Avoid high-dose miracle cure claims. If a supplement vendor promises rapid elimination of tinnitus, be skeptical. If you have kidney disease, liver disease, take anticoagulants, or are on multiple medications, consult a clinician before starting supplements. Medication review. The most common ototoxic culprits to be aware of. Examples to discuss with your healthcare provider. Do not stop any medication on your own. Aminoglycoside antibiotics, e.g. gentamicin. Certain chemotherapy agents, high-dose loop diuretics, and, in some cases, large doses of salicylates, aspirin, or non-steroidal anti-inflammatory drugs. Many other drugs can contribute in rarer situations. Action. Bring a complete medication list, including OTCs and supplements, to your clinician and explicitly ask whether any items might be ototoxic or contribute to tinnitus. Diagnostics and tests you should consider asking for. Comprehensive audiogram, the core test for hearing thresholds across frequencies. Even subtle high-frequency losses can relate to tinnitus. Tympanometry and ear exam, evaluates middle ear function and rules out obstruction or fluid. Otoacoustic emissions, OAEs, assess outer hair cell function and can identify cochlear damage not apparent on pure tone audiometry. Speech and noise testing, evaluates functional hearing in realistic listening settings, often relevant to hearing aid decisions. Auditory brainstem response, ABR, used in some cases to evaluate neural conduction if retrocochlear pathology is suspected. Vascular imaging, ultrasound, MR angiography. Consider if pulsatile tinnitus or vascular cause suspected.
MRI of the brain and internal auditory canals. Recommended if unilateral tinnitus, asymmetric hearing loss, focal neurological signs, or sudden change. Discuss with your ENT. Sleep study. If sleep apnea is suspected, treatable sleep apnea can reduce tinnitus burden. Basic labs, thyroid studies, glucose A1C, B12, and others as clinically directed. Note, not every patient needs every test. Use the history and physical exam to guide targeted testing. When to expedite care, red flags that require prompt attention. Sudden, unexplained hearing loss with tinnitus. Seek urgent ENT evaluation. This can be a treatable emergency. Unilateral tinnitus with progressive or asymmetric hearing loss needs expedited imaging to rule out retrocochlear causes. Pulsatile tinnitus, coinciding with neurological symptoms or new-onset headaches. Consider vascular evaluation. New severe vertigo, neurological deficits, or facial weakness. Immediate evaluation required. The economics and secret part, why some low-cost measures are under-discussed. Reality check. There is a large multi-billion-dollar market around hearing devices, therapy programs, and long-term management. Market size can influence which options get the most attention in advertising and clinical conversations, not necessarily which options are best for a particular patient. What this means for you: ask whether a proposed treatment is intended to manage symptoms long-term, treat a root cause, or simply sell an ongoing service. It's a fair and reasonable question. Does this help my underlying condition or primarily reduce my awareness of it? How to protect yourself. Insist on an evidence-based plan that starts with diagnosis, then targets reversible causes before committing to high-cost, long-term purchases. Ask for a trial period, clear outcome measures, and second opinions when invasive or expensive therapies are proposed. A realistic priority ladder for action. What to do first, second, third. 1. Immediate, low-cost steps you can start today. Protect your hearing, start sound enrichment at night, trial a 2-week caffeine alcohol reduction if you suspect sensitivity, improve sleep habits, and begin stress reduction practices. 2. Early diagnostic steps within weeks. See an audiologist for a full audiogram, bring a detailed history of onset and modulation, and have an NT exam. If your tinnitus is pulsatile or sudden, seek expedited evaluation. 3. Medication and lab review, short-term. Review medications for ototoxic risks and obtain basic labs, B12, thyroid, glucose, as clinically indicated. 4. Targeted therapies, over 1 to 3 months. If hearing loss is present, trial appropriate amplification. Consider CBT for distress. Pursue physical/dental therapies if somatic modulation is present. 5. Specialist options and advanced care, over months to years. Explore retraining programs, consider clinical trials for neuromodulation/drugs if you are a candidate, and reserve surgery for clearly defined structural causes. What to ask your clinician, a script you can use. Can we do a full audiogram and document baseline hearing across frequencies? Is my tinnitus objective or subjective, and was somatic modulation tested? Could any of my medications be contributing to my symptoms? Given my history, describe onset, unilateral/bilateral, pulsatile, non-pulsatile. Which diagnostic tests do you recommend and why? What are the realistic outcomes and timelines I should expect with each option you propose? Are there low-cost or reversible steps I should try before considering long-term devices or invasive procedures? Can you refer me to a clinician experienced in tinnitus-focused CBT or a physical therapist who treats somatic tinnitus? How to evaluate commercial devices and apps? Does the product have peer-reviewed evidence supporting its claims? Be wary of anecdote-heavy marketing. Is there a clear trial period and return policy? Devices that don't fit or help should be returnable. Are the claims realistic? Do they promise management of symptoms, or do they claim a cure? The former is reasonable, the latter is unlikely.
Does the device require ongoing subscription fees? Consider lifetime cost versus expected benefit. When in doubt, Ask your audiologist whether the device has demonstrated benefit for people with your audiometric profile. Coping and quality of life strategies worth adopting now. Build a daily routine that reduces exposure to silence at night. A low-level sound generator, fans, or apps with nature sounds can make a huge difference. Create a short, portable toolkit for flare-ups, a small sound device or playlist, a breathing exercise you know well, and a distraction plan for tough moments. Join peer support. Structured groups or vetted online communities can reduce isolation and reveal practical tips, but avoid echo chambers that sell miracle fixes. Prioritize enjoyable activities and social connection. Improved mood and activity reduce focus on tinnitus and enhance resilience. The research horizon: what's promising and what to expect. Neuromodulation and bimodal stimulation. Techniques that pair sound with mild electrical stimulation to reorganize auditory pathways show promise in early trials, but larger, replicated studies are needed. Regenerative strategies. Long-term research aims to restore inner ear hair cells through gene therapy or regenerative medicine, but these remain investigational for now. Pharmacologic trials. Several drug candidates are in human trials to reduce neural hyperactivity tied to tinnitus. Results are mixed and slow to translate to widespread clinical practice. Bottom line, remain cautiously optimistic. Research is active, but the most effective strategies for most patients today remain accurate diagnosis, targeted therapy, and behavioral coping. A detailed 30-day plan you can follow right now. Week 0, day 1 to 3. Baseline and immediate protection. Document your tinnitus: unilateral or bilateral, pulsatile or steady, onset date, associated events, noise exposure, medication, illness, what modulates it, jaw movement, stress. Start protective hearing measures. Avoid loud environments, use ear protection, lower headphone volume. Begin nightly sound enrichment: fan, white noise, or an app. Week 1, day 4 to 10, diagnostic and lifestyle steps. Book an audiology appointment. List all medications and supplements. Set an appointment with your prescriber. Try a 2-week trial reducing caffeine or alcohol to test sensitivity. Improve sleep hygiene, fixed sleep-wake times, limiting screens pre-bed, light exercise earlier in the day. Week 2 to 4, monitoring and early treatments. Attend audiology and ENT testing. Ask for an audiogram and ask whether somatic testing was done. If hearing loss is found, discuss trial hearing amplification. If stress or sleep are major problems, consider referral for CBT or a sleep study if apnea suspected. If tinnitus fluctuates with jaw or neck movement, ask for a somatic evaluation referral.
Month 2-3. Targeted interventions and assessment. Evaluate benefits from initial measures. Continue what helps. If amplification or CBT was started, set goals and measure changes in sleep, concentration, and anxiety. If no improvement, discuss advanced diagnostics, imaging for asymmetric or pulsatile cases, and ask about local clinical trials if you're interested in emerging therapies. Long-term, maintenance and follow-up. Reassess every 6 to 12 months or sooner with new symptoms. Maintain hearing protection and cardiovascular health. Stay informed about validated research. Avoid impulsive purchase of unproven cures. Putting the secret in perspective. Empowerment over paranoia. It's tempting to imagine that someone is hiding a simple cure. The more accurate description is this: tinnitus is a symptom with many causes, and the marketplace responds to demand. Treatments that require long-term purchases or subscriptions are financially sustainable. Quick, inexpensive fixes are less profitable and therefore less advertised. That doesn't mean clinicians intentionally withhold care. It means you, as the consumer and patient, benefit from asking focused questions, insisting on targeted diagnostics, and trying low-cost measures first. In short, be informed, be skeptical of grand promises, and be methodical. Real patient examples, anonymized patterns you might recognize. The medication culprit pattern. An older adult developed tinnitus after a new high-dose diuretic.
After coordination with the prescribing clinician and a safe alternative, the tinnitus diminished. Lesson: medication review matters. The hidden hearing loss pattern. A person had normal conversational hearing but had trouble in noisy places and developed tinnitus. An audiogram revealed high frequency loss. A trial with amplification reduced tinnitus awareness. Lesson: even mild losses matter. The somatic modulation pattern. A patient's tinnitus increased when clenching the jaw. Dental evaluation and TMJ physical therapy led to significant reduction. Lesson: check jaw and neck. Final checklist. A concise plan you can bring to your next appointment. Document tinnitus characteristics: laterality, pulsation, onset, modulators. Get a full audiogram and ENT exam. Review all medications and supplements with a clinician. Start tonight. Low-level sound enrichment and hearing protection. Try short lifestyle trials, sleep optimization, brief caffeine, alcohol reduction, stress management practices. Ask about CBT for tinnitus distress if sleep or mood is affected. Pursue targeted tests only if history suggests vascular, neurological, or structural causes. Be cautious about supplements and unverified devices. Use lab-guided supplementation and trial periods for devices. A final word on expectations. Tinnitus rarely follows a single, universal path.
For many, it becomes a manageable background condition. For some, targeted diagnosis and treatment can meaningfully reduce or eliminate the symptom. Patience, methodical testing, and combining practical home measures with appropriate clinical care give you the best chance of meaningful improvement. Avoid miracle claims, but keep hope. Research is active, and many patients find significant relief with the right combination of interventions. If this message has been helpful and you want more in-depth breakdowns, diagnostic checklists, printable questions to bring to your ENT, and a vetted list of clinical trials and evidence summaries, subscribe and check the description for resources and carefully curated links. And above all, if your tinnitus is new, sudden, pulsatile, or accompanied by other neurological symptoms, seek prompt evaluation with an ENT or audiologist. Getting the right tests early can change everything. If you found this useful, please like and subscribe so we can make more evidence-focused guides. Share this with someone whose ears are ringing and encourage them to get checked. Early action matters.